I'm Stephen Taplin from the National Cancer Institute. I was a family doc for 20 years in the Northwest before coming here. And I can't multitask. I can't introduce myself, and there we go. There we go. All right, so thank you. Thank you all for coming. Thank you, Arnie, for setting the stage so well. And thank you for your wisdom during the development of this conference. Working with Dr. Kaluzny was an incredible privilege for us, and it's one of the great things about being at the National Cancer Institute is that we have a chance to convene great people and talk with them and to bring them together and support this kind of work. So thank you for being part of this, Arnie. Also, I wanted to acknowledge that we have some others that we were able to bring in. Dr. Richard Scott, who will be talking later today, another luminary. Otis Brawley tomorrow from the ACS, who's known all over the country for the work and for his ability to say things the way they are. And so we're very excited about having all of these people here and the chance to interact. I also wanted to thank the people here you see listed on this slide who are all part of the thinking behind the conference, the thinking behind this paper, and hopefully the thinking in the follow-up, as well as taking care of many of the details that made it all possible. Lots of things happen. If the conference goes well, it's because these people have worked really hard to make sure all the details are there. So thank you to all of them. But let's start. You've heard the plan. You've heard some of the problems. Let's elaborate and let's get to the discussion. A little more background. U.S. healthcare overspends. If you look across the 19 developed countries in the world, U.S. is far and away the most expensive place to get care. But it's not, of course, that simple. It's worse than that. It's also that U.S. healthcare underachieves. If you look at what we get for our dollar, 55% of people with chronic illness get the recommended care. 55% get what's recommended in care when they come into that expensive healthcare system. We are 19th among 19 developed countries in the reduction of avoidable mortality. It's a measure of looking at, if you look at conditions in which you can make a difference, how quickly are we reducing deaths due to those conditions. U.S. is 19th out of 19 developed countries. We are 13th in infant mortality. We have a ways to go. We have things we need to do. And in the U.S., we know one thing is absolutely certain. Things are going to get more expensive. So we're underachieving, and we know we're facing higher costs. We simply cannot keep doing what we're doing, thinking the way we've been thinking. 125 billion, I'll just round it up. $125 billion in 2010, 27% increase anticipated for 2020 by my colleague Martin Brown and his team at the National Cancer Institute. So we need to do better. And in fact, that's one of the basic assumptions, is that we need to do better. We take that for granted. We also need to think carefully, and Arnie has already alluded to this, about whether the approach we've been taking and the reductionist approach of finding simple little steps that are exquisitely designed and exquisitely and validly proven, whether that particular approach can continue to work in our system. It takes a long time to get those little pieces into place, even when we're convinced they work. And then they're not always adopted, and they're not always used. So we need to begin to get out of that approach. That's an assumption. We may take that as an assumption as a starting point. We also think we can do better in pursuit of health, in rethinking our questions about delivering care, and in considering multi-level interventions. Now, the consideration of multi-level interventions is not necessarily completely new at all. People have been talking about multi-level interventions for quite a while. My colleague Erica Breslow and Helen Meisner in 2004 in a cancer supplement looked back at 20 years of screening history in which they were identifying effective interventions for 20 years in screening. And at the end of that 20-year period, concluding that they're not all being adopted. There are efficacious interventions in screening that are not being used, and we continue to generate more. And that maybe we need to step back from the reductionist approach and ask the question, what is the context in which these interventions are being implemented? How do we begin to understand and address that context and begin to think about that before we're faced with the task of implementing? And so we are taking that as a basic assumption, that in fact the reductionist approach has not worked completely well. It certainly has contributed many things to what we know, but we want to step back, as Arnie says, rotate 90 degrees perhaps, look at the runway in a different way, and begin to think about what we're doing in a different way. So let's define a couple of terms here because we've been throwing them around already. One is multi-level interventions. So what exactly is an intervention? And when we're talking about an intervention, we're saying specific strategy or set of strategies designed to change the knowledge, perceptions, skills, and or behavioral of the individuals, groups, or organizations with the goal of improving patient health outcomes. So we are trying to think about the context directly linked to patient health outcomes. And we are looking at whole sets of strategies to do that. We're also defining levels in a particular way. And we're saying that they first are patient-centered, so we want to be, as we said, linked to health outcomes. We want to look at a measure at the patient level, but then target at least 2 other levels of a multi-level model of improving health status, which I'll explain in just a second. And then we also want to measure effects at each of these levels. Now, we set out with this definition at the beginning as a sort of stake in the road, stake in the ground, a place to begin. And when we then started to look for literature. Could we find examples in the literature beyond cancer, anywhere that we could find that would meet those definitions? And we found a very sparse literature that would meet those definitions. We actually, looking back, I think 15 years, we actually could find only 3 which were clear multi-level interventions in which there was a clear intervention at least 3 levels, and these are the 3 tests. And I think you all, if you've been around, and I can tell that some of you are gray, that you've been around a little bit, that commit, assist, and catch are all pieces that we've heard about. They have addressed 3 levels: individuals, organizations, communities. They've measured some outcomes, smoking cessation in a community, or smoking or cholesterol levels and BMI at an individual level, but none of them actually address all 3 interventions with measures at all 3 interventions. And so we decided that we needed to do more, and that we would do that not based on the fact that there was a clear, compelling evidence that multi-level interventions work. In fact, it's not there. But because the reductionist approach has not worked completely well for us. It has developed little bitty steps, but we need to be stepping back. We need to rotate 90 degrees and look at the runway in a different way. So we decided to convene a group of people to start. Many of them are in the room. To begin to generate the issues and generate a set of recommendations, and we convened in June of 2009, and as a result of that meeting, we gathered together a set of topics to talk about, and that is the basis of the supplement that Steve has already alluded to that will be coming out, we hope, in the fall of 2011. The supplement topics are the focus here, and as Arnie has already alluded to, we're going to, first, section 1, talk about definitions. We'll also talk about, Jane is going to elaborate on a couple of cases that use multi-level thinking, and then Kurt Stange is going to tell us about the state of the art in that area. Section 2, we're going to be looking a little bit harder at conceptual issues. Brian Weiner is going to talk about how you conceptualize a synergistic intervention. To look at time. Time is a critical issue. Paul Cleary is going to talk about design, and you'll see down there Marty and Joe are going to add their thoughts. Section 3, we'll get back to reality a little bit and focus on what's actually happening in care here in the United States. So we look forward to an exciting set of papers. And we look forward to your comments. As you've also heard, we want your input, we want your critical thought, we want your skepticism. This is the time to step up, and we look forward to hearing from you. So session 1, multi-level influences and interventions across the cancer care continuum. And now I've defined levels, and I've defined what we mean by interventions. But let me get a little deeper into levels and acknowledge that the way that I've already alluded to in terms of levels is only one way to do it. There are other ways. And there's ecological and psychological models that talk about interpersonal and policy level. There's system models, individuals and groups, organizations, economic and social systems. These are all ways that are out there in the literature that talk about multi-level interventions. We have chosen a biopsychosocial model developed by a person from Rochester, New York, which is where I trained as a family doc, and that is George Engel. He looks at individuals, groups, organizations, communities in the nation, really looking at the aggregates of individuals as, for us, as potential targets of interventions. And so really, we take that model as our model, the layered context of care is what we call it. We also call it the onion. And when we look at that layered context of care, we expect that the effects of those layers will improve, that if we address factors in those layers, we can affect quality and we can affect outcomes. But it's also clear that this is a cross-sectional view, and that outcomes and care is not a single event, that in cancer, care is a continuum, that there are a number of types of care, from looking at people at risk in the population to thinking about primary prevention, so changing diet, changing physical activity, thinking about detection or diagnosis, and each of these types of care needs to be addressed in order to move somebody all the way across the cancer continuum. So there is a time element, there is a longitudinal element, but there's also an element, and a fact that I think any practitioner in the audience knows, that it's the connection between the steps as much as the steps that matters. And if you're in the middle of the care process, it's how you link people up and link organizations and link the steps that actually makes it possible to traverse that entire continuum. So we think also about the transitions in care, and it's the transitions and the types of care, it's those two pieces together that address the quality measures that we all know so well from the IOM. And that those quality measures then affect patient outcomes, and we can look at patient outcomes at the individual level, their biologic outcomes, their quality of life, or we can look at the population level, the summary across all the individuals to look at mortality, or look at morbidity, or look at cost effectiveness. And when you break down that continuum and think about that cross-sectional association, or think about the links between, the more you look, the more complicated it becomes. There are, in fact, multiple little steps between types of care. So you can think about how results reporting occurs. How is it that the result of a test actually gets to the individual? Who's doing that? How is the test getting to the person that's supposed to get it to the individual? And as you begin to take apart the care process, there are, in fact, lots of little steps, lots of little places where the organization and the context in which care happens can affect that step. So it's a way of thinking about care as a longitudinal rather than a single event, as a longitudinal rather than a dyadic discussion between a doc and a patient, but as a process overall. And that's a critical step in understanding, we think, and I think, in understanding the process of care and understanding the potential influence of these multiple layers on that process of care. And then when you string out that process of care, you begin to think that, in fact, it is a long series of events, and as a person enters that, they are then affected by family and social support all the way across that continuum. They are affected by providers, a set of providers, all the way across that continuum. They are affected by the organizations all the way across that continuum. And they are affected by the communities in which they live and the communities in which that care occurs all the way across the continuum. But, of course, it's not that simple. In fact, if you look at it, there's reason to believe that the effects are different at different points in the continuum. So family and social support may be very important at the beginning, and providers may play less of a role. But as you move into the detection and diagnosis and treatment part, providers become a bigger factor. They are more important to actually what happens. And family are still there, but may play a lesser role. And if you get to the end, it may jump back. Families and social support may vary again and become higher. So that the factors are not monotonic. They are varying across the continuum. And we haven't even thought about organizations and communities, which also are going to affect and going to change their influences across care. So we're beginning to create a very complex process, it's clear. Multiple layers affecting particular processes in care in a longitudinal effect over time with varying levels of effect. And how do these levels affect each other? It's another critical question. And I think it's one of the questions, at least as I started to read the literature, where I got a little bit confused between what's a level and what's a mechanism of influence. And so our structure, is policy a level? And there are papers out there that use policy as a level, or is policy just a way of one level affecting another? That in fact policy can be at a national level, can be at a state level, could be at the community level, could be in a team that can set policy. So I tried to separate out the factors that are levels, human sets of aggregation, and factors that are ways that those levels influence each other, and think about structure, policy, incentives, interpersonal interaction to affect people, those are all mechanisms and potential ways that you would organize an intervention. So care occurs in context. I'm not sure what's going to happen now. Oh, there it is. And it's a complicated context, and we need to think about it. Any provider who has worked within this context knows the richness and knows, I think, has experienced coming back from a continuing medical education program, excited about something new you've learned, and then try to put it into practice and figure out that there's resistance. It doesn't quite go the way you think it's going to go. And so I think it's important to get a good feel for that and to think about how the multi-level context affects us every day in delivering care. Now, this is a gamble, whether this is going to work. So care is a process. We can begin to think about national level policy, medical reimbursement, all affecting care. We were quite concerned that no matter what we did in this meeting today, if they shut down government, we would be going home tonight. That didn't happen, thank heaven. There's state health policy, medical reimbursement. There's local community environment, community level resources, local hospital and cancer services, local professional norms, all affecting what happens within that community and how those processes get delivered. There are practice setting differences. How does the physical structure within the practice allow communication or inhibit communication? And there are team factors. Do people actually practice in teams, or are they just parallel play in groups? There's also the family, how you connect to the family, whether you incorporate the family in the discussion or not. And then there is ultimately the individual patient and how we think about talking with them and interacting with them. So it is a complicated world. We can build from the individual and go to the national. We want to think about all of those levels, but focus, as Arnie said, primarily in the individual, family, social support provider, and communities, or organizational settings. So, for discussion at the tables, we hope that you will ask the question, what is a level? Not to reflect necessarily, or you can reflect what we've said, but to look critically at the question that I've raised and ask, is a level really, is a unit of organization an easy way, a good way, a useful way? Are the alternative ways better, worse? Why? So think carefully about level. How is the level distinguished from the mechanism of influence? How do levels affect each other? What difference does it make in terms of how we design levels and how we design interventions? And I look forward to your discussion.